PowerPoint presentation that she sent you guys, because it'll help you differentiate the types of diseases and disorders by their nomenclature. So that way you can tell if one's a macule, a papule, a plaque, a patch. Just kind of helps you kind of get familiar with what that is, and when you look at something, what it could be. Probably a blessing that she sent it to you guys, because I think it's like 100 slides, right? You guys would have been here for 3 hours. So, but if you would look at that while you're studying, I probably would look at it today if you can, or this evening or tomorrow. That way you don't get behind on the nomenclature and the morphology and how a skin lesion looks and how you would describe it. Because I was telling them that it's really big in the dermatology world is to know what you're looking at and how to describe it to somebody. And the big thing is also measuring. How do you measure it? And how you do, because like you guys have learned when you do your notes, it's hard to describe something if, like what's the right terminology. And so it will also help you with your midterm exam if you look at the morphology PowerPoint presentation that she sent you all. Having said that, today we're going to talk about papillosquamous disorders. I put a little definition. Oh, this is a lecture objective. So basically, I want you guys to learn the etiology, physiology of the main topics we're going to talk today, which is lichen planus, pityriasis rosea, and psoriasis. And basically, I want you guys to realize what a patient looks like when they present to your clinic. What does the lesion look like? What are their complaints? Does it itch? Does it burn? Does it bleed? Those kinds of things, and to know which disorder it could be. And then we're going to go into psoriasis, because psoriasis has a lot of different types. Lichen planus does as well, but not as many as psoriasis does. So I want you guys to learn how to differentiate between the different types of psoriasis and where you normally would find it. And then again, the morphology of the lesion. So are they flat? Is it planar? Is it oblong, oval? That kind of stuff. And then treatment plan. The nice thing about derm, in which you guys already got Dr. Latassi's lecture, is usually it's keeping it moist, because if it's a dry lesion, or keeping it dry if it's a wet lesion. And then most everybody slaps steroids on things. So I don't know if she guys gave you a big whole list of topical agents today. Did she go over most of those? And then with lichen planus, there are certain diseases that you look for in someone who has lichen planus, and so I want you guys to be able to know which disease that is most commonly associated with lichen planus. So what is the papillosquamous disorder? It's a condition that has both papules and scales, or they have both scaly papules and plaques. So again, just looking up those words and what they mean can help you when you look at a picture of something, kind of helps you just kind of cut it down to what they are. Like I said, we'll go over lichen planus, pityriasis, and psoriasis. So the first topic is lichen planus. So it's basically a idiopathic, that I don't really know what causes it, eruption of shiny, flat-topped, hence the name planus, purple papules, and plaques on the skin. And it's usually, most of these people, if they have it on their skin, they also have it in their mouth. They will also have these lesions, these raised purple lesions inside their mouth. And normally it's on the buccal mucosa. Sometimes you can get it on the gums, the tongue, but the majority of the time it's on their cheeks, inner cheeks. And what causes it? It's usually an autoimmune disease, usually T-cell mediated. Anybody can get lichen planus. Most commonly in adult females. Most of my patients I had were all females. I rarely had a male that had lichen planus in the mouth. Again, I only saw mostly mouth lesions. Most of the dermatologists will see the ones that have the skin. You can also get it acquired from certain drugs that you take, or toxins, chemicals. Here's a little list of them: thiazides, furosemide, beta blockers, diabetes medications, malarials, anti-malarials, gold salts, and ACE inhibitors. Rarely you get photodeveloping chemicals, dental materials. What they mean there, sometimes you can have a crown or a filling that can rub up against it and cause a local reaction, inflammation, and develop lichen planus. You can also get it from tattoos. Sometimes people can get it from Someone has what's called familial bullous lichen planus, and then sometimes they can develop it from henna pigments or tattooing. So, like I said earlier, the most commonly associated disease with lichen planus is a Hep C virus infection. So, particularly in Asia, South America, Middle East, and Europe, so not commonly here, but anytime you see someone who has widespread lichen planus either on their skin and the oral mucosa, so you would want to get a hepatitis panel, just to rule out hepatitis C. So lichen planus has also been reported and associated with other diseases, basically other autoimmune diseases. It seems like once you have one autoimmune, it seems like everyone, you can get a plethora of them, because basically your body's attacking itself. And so these are just a list of them. Bullous pemphigoid, which you guys will get later. Alopecia areata is basically balding spots on your head. Myasthenia gravis, did you guys say that in neuro? Okay. Vitiligo, which is a skin condition where you get light patches throughout your skin. Ulcerative colitis, you guys go with that GI. Graft versus host reaction, so I've had that in a patient who was a kidney donor. So she developed all these weird ulcers in her mouth, but I think it actually ended up being, when I biopsied it, being CMV or cytomegalovirus. So you can get lupus, and then you can have what's called a lupus erythematous overlap syndrome and lichen planus syndrome. Because the lupus, have you guys learned about lupus already? Yeah. You get that malar rash, on their face. Sometimes it kind of overlaps with that. So these are the basic classic lichen planus. Again, you get small, flat, angular, red to violet, shiny, and sometimes they can be itchy, papules or plaques, and they are always associated with a tiny white fine lines that we call Wickham stria. So you'll see it's like this, it's interwoven, or on top of these plaques you'll see like this thin, fine white line, and usually if you put like oil on top of it and you use a hand mirror close, you can really see the stria on top of these lesions. And that's usually indicative of lichen planus. And usually you'll see them on their wrists, on the lower extremities around their ankles, lower back, and you can also get them on the genitalia. So, and then obviously the oral mucous membranes. So like I said earlier, when you look, and I'll show pictures in a minute, when you look on the inside of their buccal mucosa, it'll have this fine reticular pattern is what we call it, lacy appearance, and it's kind of a purplish white hue on the insides of their mouth. Now if we all looked in all of our mouths, if we all have anxiety, which most of us probably do, you'll see a little thin white line on your buccal mucosa. That's normal, but what you'll see is this lacy appearance on the inside of their mouth. Sometimes it's onto their gums. One lady I had, it was all on her cheeks, on her gums. You can see the same white lacy pattern on the inside of her gums. And for her, she would get these ulcers, and so they're really painful inside her mouth. Sometimes these are asymptomatic, they have them forever, and it never bothers them, they just notice they have it in their mouth. More often they may have itchy skin, rather than the oral mucosa that bothers them. And you can develop thick patches of rough, scaly skin, probably from the itching, so the more you itch, it's like an itch, scratch, itch, like with eczema, which you guys will learn that as well. It's the itch that keeps on itching. So basically, itch, they scratch, itch, they scratch, and then the plaques get thicker and thicker. And so they say blisters are pretty rare, but we get more ulcers, like in their mouths, they're just more like open sores rather than, a vesicular blister. But you can get them around the genitalia, so it kind of just looks like a raw area of skin, and that kind of can be painful. So sometimes it can just come up all of a sudden, or it can be a gradual course, and usually they resolve by themselves. And some people, though, can have bouts of it in and out for many years. Well, they'll come in, they'll see you, and they'll need just a steroid mouthwash for their lesions in their mouth, and you won't see them again for 6 months, or you may not see them for another year. It just kind of depends. Earlier, like I talked about, you can have drug-induced lichen planus. The difference is they look like lichen planus, except they don't have that Wickham stria. And then they normally don't involve the inside of the mouth. It's usually skin. And sometimes it may not develop in months and years till after they've been on that medication, but usually they'll go away once you stop that medication. But again, some of these rashes take forever, so this one too can take a long time before it goes away. So this is just kind of a summary of the signs and symptoms. Papules, they can be small, up to 10 millimeters in size. Again, it's small, shiny, flat-topped, usually in crops, and they may have a fine scale. So usually purple in color or violet color with the white lacy pattern. Shape polygonal or oval. You can have what's called a Kevner phenomenon, where you may see new lesions from just areas where they've been injured or had a scrape or burn or something like that, that all of a sudden they develop a patch of lichen planus there. And that's again just the distribution where you would see it. And usually once these lesions heal, they can be left with what's called a post-inflammatory hyperpigmentation. And it's just a fancy term for a dark patch. So a lot of these lesions can heal. The only way you know you've ever had it is it just heals with a bad scar. Again, usually it can go away within 2 years. Approximately 1 in 5 will have a second outbreak. But like I said, it can come and go for years. This one lady I know, she's had it, all of a sudden one day she propped up with like the crop of them in her mouth, and she was given oral steroid rinse, and she never had a problem again until the next year when she showed in my office. So you just never know. And you look in her mouth, she has all this white lacy appearance. When you see one for the first time, it's kind of cool. But this is what the lesions look like on their hands. So how you see how that one kind of has on that hand, it has like a little bit of a purple hue to it, right here. Kind of looks purpley, white. This one's a little harder to see, but see how it's little crops of them, and they have a little bit of a scale. You can kind of see if you look closely, they have a little bit of a scale to it. But it is a macular papular because they're raised. And so this is signs and symptoms of oral lichen planus. So I've kind of already talked about it. 40 to 60% of patients have skin lesions as well. And then 20% just have it without having it on their skin. It's just only in their mouth. Again, like I said, they're mostly asymptomatic. Some people may or may not have pain. And sometimes when you look at them, if they're not very prominent, if it's in a male or a smoker, you kind of worry that it looks like leukoplakia. Or we have what we call the dippers, when they pocket into their bottom of their mouths on each side, they'll have like this white, thickened, sometimes it's not thickened to where it looks like a leukoplakia, but it's just I can't remember the term that we use for it, but it's a dipper's pocket, and it has this white lacy appearance, so sometimes it can kind of look at that like that. And actually oral lichen planus, they say it generally doesn't turn into a cancer of the mouth, but it can. But it's very rare that you would have that. But that's something you always tell the patients, and that it is a possibility. So if they have it, you try not to make them, make sure they don't smoke or anything like that, or drink that would increase their risk of making it turn into a squamous cell. So again, it can involve the genitalia area. And like I said, the buccal mucosa ones or the oral ones tend to last longer than the skin, and it's just harder to treat. So here's a picture. So see they have kind of this white, kind of lacy appearance on the inside of their mouths. This one's a little bit thicker and scarred down than the ones I usually see. The ones I see are like this one. It's more just very barely there. So you really have to look, and that's why it's important when you look in someone's mouth, you always have a light. Because if you didn't have a light shining in there, there's no way you would actually really see that. But these are that little white lines. And on the gums, sometimes when they're on the gums, it can be real red, and swollen. I should have taken a picture or showed one to you guys. But on the gum line, they'll be like a dark red, and they'll just be all along their alveolar ridges right there. And you can also get lichen planus in the nails. So You basically get like a thinning of the nails. It kind of looks like this, like the white thin stria upon the nail beds. You can have thinning or splitting of the nails, and then sometimes you can actually just lose the whole nail. And you can also get it in the scalp, which is called lichen planopilaris. It's more rare. It's more common in women, but basically you'll get like this, the scalp is red, irritated, and has these small tiny bumps, and then what happens is that you lose patches of hair and you'll have scarring in that area. So this is a picture of the lichen planus on the fingernails. And then it's kind of hard to see in that picture. I couldn't get a real good picture of the lichen planus pilaris. It's tiny little bumps like that, and usually it's a little bit more red and irritated. And then when it's, you know, once they scratch and scar down, it'll leave an empty patch of hair usually. So how do you diagnose lichen planus? Usually it's by history, but you can also take a skin biopsy if you're ever unsure. You can, I don't know, usually on the skin, I can ask Amy about that, but I think you just do a skin scraping, you get the top layer off of it, and the buccal mucosa, just take a small punch biopsy on the inside of their mouth. It'll give you a definitive diagnosis. And like we said earlier, if they have skin and oral lesions, you want to check for hepatitis. So you do a hepatitis panel on all those patients, and a current liver function test. And then you can do what's called a direct immunofluorescence that helps distinguish between lichen planus and lupus. And that's something that you would have the pathologist do. Treatment, there's no cure for lichen planus. Like we talked earlier, it often goes away on its own. You can put a topical steroid on there to relieve if they have itching, give them itching. If it's in the mouth, you want to give them a steroid to calm down the inflammation. You can give them systemic steroids, especially like I said, if they have had lichen planus rash or lesions that's lasting longer and doesn't spontaneously resolve, you could do that, or if they have a lot of sores. Cyclosporine is very effective for severe chronic disease, and that's a immunosuppressant. And you can also do what's called PUVA, light therapy. Did Dr. Latassi talk to you about what PUVA is? So PUVA is, the medication is Serolin, and you can take it orally or you can apply it topically to the skin. And then basically that medication makes the patient more light sensitive or photosensitive. So then they put them under UV radiation, and that helps just calm down that inflammation and helps get rid of it. It's used a lot for patients who have psoriasis, and we'll get to that in a minute. Does anybody know anybody with lichen planus? Okay, so here's the pearls, the 7 Ps. So I wrote it out for you guys: purple, planar, polyagonal, polymorphic, pruritic papules that heal with post-inflammatory hyperpigmentation. So remember that. So people who have it in their mouth or on the genitals, you need to make sure you look at them often, if not every 6 months, at least once a year, to make sure it doesn't change or it can turn like into a cancer or anything like that. And again, what we talked about earlier, that has an association with hepatitis C. So always make sure you check lab work on these patients. And the next one is pityriasis rosea. So what is that? And it's basically an idiopathic, again, unknown, self-limited rash on the body, and it has widespread papillosquamous lesions. So in pediatrics, they usually have them on the face and the distal extremities. In adults, it's usually on the trunk and the lower, and the legs and hands, I think. But mainly I remember pityriasis rosea as on the chest and trunk. It usually affects people from the age 10 to 35, but can occur at all age groups. It's common in pregnancy, so if you're working at OB and you see a lady with this, you'll know what to do. It's more, it says predominantly the male, female is equal, although I feel like if it's common in pregnancy, the predominance would be more women than men. But no racial predominance in this type of rash. So how does it occur? People really don't know. So if you look at it, you think, okay, it looks like an allergen or a fungus, because it kind of looks a little bit like tinea, or what we call a ringworm. So they kind of have the initial patch kind of looks like that. And it also can cause, look, you might think it's some bacteria that causes it, but they think that it may be a viral antigen or an autoimmune disorder. So those are the things that it may come from. So studies have shown the human herpes viruses, most commonly number 7, and then also associated with influenza A, H1N1. But it's not contagious. If you looked at these people, you would think it looks contagious. You want them to stay away from you because it's a pretty big rash. But so again, you can also have it from other drugs like gold injections, captopril, interferon, omeprazole, and bismuth. So the most common initial sign for pityriasis is they get what's called a Harold patch. And it can range from like 2 to 10 centimeters in size. And it's basically they'll have this oval looking scaly rash that appears suddenly, usually on their trunk or their back. Sometimes you can also get it on their neck. And then like 7 to 10 days later, they'll have those smaller versions of those throughout their whole body. But they're usually salmon colored to light brown. And the scales are centrally, and they have a, what do you call it, collarette of loose scales along the borders. Again, like I said, it's usually on the chest, abdomen, trunk, arms, and legs. I've never seen any lesions inside the mouth, but you can have lesions in their mouth as well. The smaller ones are usually smaller, only 1 to 2 millimeters. And again, spares the face, hands, and feet in adults, but not in pediatrics. And again, they can occur on what's called the skin cleavage, and we call this the Christmas tree pattern. And that's how I remember pityriasis was Christmas tree. So if you see a picture and a description of something like that, and you look at it, I never really saw the Christmas tree, but they call it a Christmas tree pattern because it goes in the middle of your back and it kind of splays out like that, like a Christmas tree. And differential diagnosis is secondary syphilis, because anytime you have a single lesion, a viral exanthem could be just from a virus or something, that's something with rashes, it's hard to tell unless you see them and see them often enough. Drug rashes, it can look like psoriasis, again with the scaling, eczema, or lichen planus, and again, tinea corporis, just because they have a look of a ringworm rash. So there's the Christmas tree. I really still don't see it, even though it's drawn on there for you as a Christmas tree. But that's that little Harold patch. So usually something like this will show up. So if you just looked at that without anything else, wouldn't you think it could be a tinea, like a ringworm? But then eventually, a week later, they start developing little lesions like this. And so here's another example of a Harold patch on somebody's neck. And then these are just more smaller papillosquamous lesions. So his is all on his back, in his lower back. So the key terms for if you hear of a Harold patch, or if I describe something and you would know that it's a Harold patch or a Christmas tree pattern, it would be pathognomonic for pityriasis. So with this, you really don't draw any labs. You could do a blood draw to rule out syphilis if you suspect it, depending upon their history, their sexual history, or anything like that. How do you diagnose this? You can get skin scrapings. You do what's called a KOH prep. And then you can do what's called a dermoscopy. And that is, most dermatologists' office will have it. You as in family practice would not. It's basically this little handheld magnified mirror that you can really look. Has anybody used one or seen one of those before? It really helps to look at lesions, and it's more magnified than what the normal eye would see. I remember my friend, she works in dermatology up in Tulsa, and I went up to visit her, and she happened to have her dermoscope at home. And you guys all know I'm a hypochondriac, right? I had a new lesion show up in my hand, and I was like, oh my God, I have an acral melanoma. So basically, because it's common in Asians, you get melanoma on your hands and the soles of your feet. So if you guys ever get a new mole on your hands or the soles of your feet, run to the doctor. Well, I'm just kidding. But anyway, you can actually look with the dermoscope, and there's I can't remember what the actual term was. She's like, because when you look at it, you can see the ridges of your skin. So they say if the pigment is dips into the ridge, that's more likely a melanoma. But if it doesn't dip into into that ridge, then it's not. That's more of a benign lesion. So they use that a lot to look at lesions that you're like, I can't tell if it's suspicious or not. They will use that to help them differentiate before they actually have to biopsy. And here's just a little snippet about what dermoscopy is. But that's a little handheld thing. So this is what you see on the naked eye. You know, so you can't see it very well, but when you look underneath it, it gives you just, it splays it out better, you know, when you look under with the dermoscope. So if someone has an SCC and or a BCC and a seborrheic keratosis. I don't know, that must be, that looks more like a BCC. Which you guys will learn that, which we kind of learned a little bit in head and neck, but we really talk more about basal cells on the skin. So how do you treat lichen planus? Usually goes away without treatment. It can last 6 to 8 weeks, and as little as 2 weeks, and sometimes longer than the normal 6 to 8. Again, if they itch, you want to give them antipyretic. You can give them Claritin, Zyrtec, or you can give them a topical antihistamine. Oatmeal baths, which I don't know if you all did that when you were little, when you had chicken pox. Your parents stuck you in with oatmeal baths. That will help with itching as well. And again, once they heal, they can have hyperpigmentation. So in darker skinned people, or like myself, if I have a rash and then, or even a scar, I can hyperpigment easily. And again, this is the pearls of pityriasis. You have the history of a Harold patch preceding a generalized rash. How do you treat it? Itching, blah, blah, blah. So they say high-dose acyclovir has helped it, because if they think it's a viral cause, you would give them an antiviral, which is Valtrex. Okay. And see, I try. I feel like I'm at a good pace, but I'm already only 30 minutes in. We're at psoriasis now. I don't understand. How do people sit here and talk for 2 hours? We don't. I know. Actually, when I was creating this module, I was like, you know, the students are going to love it because it's me and Amy. Amy doesn't. She's maybe quicker than me. I don't know that to be true or not, but I was like, they'll love it because I want to sit here for 4 hours. But I may it's testable material for 4 hours. Does that make sense? Yeah. But I was like, okay, I'm going to try. I'm going to really try to tweak it out to at least an hour. I was like, 50 slides, surely I could do it. It's a minute a slide. I know y'all aren't. Okay, psoriasis. That's our last topic. Now this is more common. Does people know anybody with psoriasis? Okay. You know what famous celebrity has psoriasis?
Kim Kardashian.
I didn't y'all know that.
She's self-treated with cortisone.
But I've never seen it. Like, she must just have it. I saw one
Stole
episode where
it.
she actually had a flare up on her legs, but I haven't seen it like.
Sister's breast
She just has high.
Apparently it's like the best thing for it. And she said it worked on the episode.
I think hers are mainly on her legs,
Yeah.
for show.
right?
Yeah.
Yes.
I know our medical record.
Yeah, and I guess here's the thing is, if you don't scratch it, then it'll get thicker. You know, that's the only bad thing about psoriasis. It thickens and you get thickened plaques. What else can get thickened plaques that we already discussed today?
Itching planus. The only thing we've talked about.
See, what I'm going to do, I'll give you a picture and give you thickened, you're like, oh my God. So then you rely on the picture. Okay. So psoriasis, it's a chronic inflammatory disorder commonly characterized by cutaneous erythematous papules and plaques with a silvery scale. That basically tells you what psoriasis is. If you look at someone who has a thickened plaque and it looks silvery, scaly, then most likely it's psoriasis. How does one have it? Usually it's a combination of things. They say it's autoimmune as well as genetic. So if your family members, your mom, dad, grandma, someone has psoriasis, you're at higher risk of getting psoriasis as well. And you can have flares. They say stress can bring on it, flares of psoriasis. So stress, like if you had psoriasis, you're in PA school, you might have flare-ups of that. Psychological, anything that's, again, stress-related. Infectious, sometimes if people are sick of some other chronic illness or have a bad infection of some sort, they may have a flare-up of their psoriasis. And environmental factors. So triggers, again, stressful event. It can also occur after having strep throat. Certain medications, cold, dry weather, cuts, scratches, and sunburns. Those are all things that can cause it. Skin diseases, so psoriasis, like I said, is a skin disease that has multiple different phenotypes and different degrees of severity, like you said. You know, maybe Kim Kardashian has one that's not quite as severe as others. Who's the guy that has the psoriatic arthritis?
Phil Mickelson.
Again, he's the only one that I remember just because of the commercial with him and his psoriatic arthritis. I don't know anybody else other than on TV. Okay, so epidemiology and risk factors. Like I said, it's more common. 7.5 million people in the U.S. have psoriasis. About 80% of them have plaque psoriasis, so obviously that's the more common one. Can occur at any age, but normally in young adult to 15 to 30s. And then you can actually have, it's kind of bimodal, so it can occur again in the 50s and 60s. It's more common in Caucasians. And risk factors, again, like I said, family history is a big one. If you've had any trauma, irritation, infections, strep is a big one, mental stress, and medications. And so this is the big genetic predisposition. So 40% chance of having psoriasis if you have a first-degree relative that has it as well. I'm pretty sure my dad has osteoarthritis and I'm going to have it too. I can already tell my fingers. It's true, Shelly, it's true. Look, when you guys go, hey, what is this? What is this called for osteoarthritis?
Fingers?
You can't see it? Where's my little nubbin right here?
What is it?
It's a little nod
I
right
thought
at my
it was for
joint.
RA.
Digital matrix.
Some digital mucus.
The volar plate injury.
No, yeah, like if you've seen someone with bad osteoarthritis, they have like two of those little round little knots right here at their distal.
There's two, there's a different one here. One's B and one's C, but I don't remember. She knows it.
What is it, Jimmy?
The Hebridean notes?
Yes.
Love it.
I kind of remember that, and then what's the other one that's like a bow?
The sharks.
Yeah.
Yeah.
It's the B.
Yeah. So I remember that. Okay. So again, these are the main signs and symptoms of someone who has
Welcome back,
psoriasis.
Sam.
Well demarcated salmon, pink to red, papules and plaques with a silvery scale. What else is salmon colored? That one I just told you about.
Salmon.
Harold patch. A Harold patch. And what disease is that?
Syphilis.
Okay. Again, they favor the scalp. It can have in what's called your concha bowl, so the little part right there in your ear. Behind the ears, on the extensor surfaces of your extremities, knees and elbows. You can also have it in the belly button, lower back, and so that kind of goes into other diseases that we'll talk about. You can have the nails, and there's something called Auspitz sign. Basically, you have pinpoints, underlying pinpoint of bleeding when a plaque is pulled off. So that's pretty indicative of that it's psoriasis. And again, you can have a Kevner phenomenon with this as well. And genitalia affects up to 40% of patients. That would be horrible. And then sebal psoriasis. So psoriasis can overlap with what's called seborrheic dermatitis, which you guys will learn here after a while too, as greasy scales. So you can have them on above the eyebrows, the nasolabial folds, and postauricular and pre-sternal areas. So you can have, like, if someone has seborrheic dermatitis, you see someone who has, like, if you ask them, do they have dry skin, because they're always complaining that their skin is dry, it's over their eyebrows, nasolabial folds, and preauricular, it's usually seborrheic dermatitis. But I guess you can have both overlying with psoriasis as well. So this is that OSPIT sign. So you can see those little pinpoint areas of bleeding, and that's when you scrape off a psoriasis plaque that you'll get that OSPIT sign. Like you can get that with a scab too. But for test purposes, this was psoriasis. So now we'll kind of go into the different types of psoriasis. Again, the most common one is plaque psoriasis. 80% of cases, and that's just another, again, description of what plaque psoriasis is. Anywhere on the skin, commonly, and it itches. So when it itches, you scratch, thicken plaque. So this is pictures of plaque psoriasis. I've seen patients with it under their scalp area like that. And obviously, a lot of times I see it mainly on their elbows. I see a lot on the elbows and the scalp. Can't tell where that bottom picture is at. Looks like on their leg.
Or it could be a arm.
Could be side. Can't get that. But again, you have that red looking with all that silvery scales. And usually when you see psoriasis, you'll know it's psoriasis. The second one is called guttate psoriasis. It's not very common. It's less than 2% of psoriasis patients, usually in patients less than 30 years of age. They just show up with a 1 to 10 millimeter droplet-shaped pink papules and fine scale over the trunk and their extremities. Normally, these are the patients that have it. They've had strep infections 2 to 3 weeks earlier. So sometimes you kind of get that mixed up with when people have that scarlatine rash, or what it is after. It's more like a sandpaper rash after people have strep. This is a little bit different, but this usually is preceded by a strep infection. So it may clear up in a few weeks or months without treatment. So if I gave a scenario of a patient with papular plaques and they had strep infection beforehand, your answer is guttate psoriasis. So that's what it kind of looks like. Doesn't it look horrible? This one looks horrible right here. Like he's just been scratching so bad down there. And you know, I don't know if you guys ever seen anybody with a scarlatine rash after having strep. Theirs is like more fine, small little bumps, and it doesn't have I don't remember it really having a red rash to it or look to it, but it's real scaly. It really feels like sandpaper when you touch their skin. So this is guttate psoriasis, but small little papules all on the back.
Would you wear gloves when you're feeling this or no?
It's not contagious, so it's just how comfortable you are. I can say I've done some things and looked at a rash and touched it without gloves on, but you probably should to protect yourself if for some reason it's something contagious that you have. A lot of times, like at the health clinic, I get a lot of little bumps. You know, students come in with like little bumps on their belly, on their abdomen, on their back, and I'll look at it before I put gloves on, but if I feel like I need to go ahead and touch them, I will put gloves on. But a lot of ours is bed bugs. Oh. I see a lot of bed bugs. Like, when I ask them to describe it, how it started, and it has like a linear pattern on them, I'm like, you might want to call your RN because I think you have bed bugs. And I always suspect a bed bug if their suite mates have bed bugs. Because she actually had it before. She thought she had bed bugs, and they came and checked her room, and they didn't see anything. Well, then all of a sudden, her suite mate ends up with bed bugs. And I'm like, probably because they traveled from your room to her room. And now they're back in your room. They liked you so much, they came back. Okay, you can have what's called inverse psoriasis. So this affects intertrigus areas, like underneath the breast, armpits, anywhere you have skin to skin. So anytime you hear the term intertrigus, you think of anywhere you have folds. It's folds of skin that touch each other. So when you get candidiasis in the intertrigus, it's usually in the breast, in the thigh area, anywhere you have folds of skin that touch each other. Obviously the genitalia, the buttocks, anything like that. So basically they get pink to red plaques. The only difference is They don't have very much scaling. But they also look raw, so it's hard to decide is this a psoriasis I'm looking at, or is this a dermatitis, like a yeast infection? So, how you distinguish it is the satellite lesions. So usually with a candidiasis, intertrigus candidiasis, you'll have like little satellite lesions. I don't know if you've ever seen anybody or a grandma, or you worked in a nursing home, they usually get a lot of yeast, especially if they have large breasts underneath there or underneath their pannus. So it gets real, again, the folds, and it trap moisture, and they can get yeast infection between those. But if you've ever seen them, they both look raw, but the only difference is with the yeast, you'll have little satellite lesions. So this is what inverse psoriasis looks like. So can you see how there's a little bit of scaling right here around her belly button? Right there, but for the most part, it doesn't have that scaly look of normal psoriasis. But you don't have those on, if someone were to show up like this, but they had like little red lesions here, little dot there, you would think more yeasty. Because you can have people show up like this all the time, especially underneath the armpit. But again, you'll look for little satellite lesions to determine if it's, if you differentiate from a yeast versus a psoriasis. This is the worst of all of them. It's called erythrodermic psoriasis. It's very rare. Basically, they get generalized erythema and scaling, and it covers greater than 75% of their body surface area. And basically, they have desquamation, hair loss, nail dystrophy, and systemic symptoms such as fever, chills, malaise. So these people kind of feel bad and they look bad. So some of these people may require hospitalization because if they're not feeling good, they're not drinking, they get dehydrated, and then they have, their electrolytes get out of whack. And with these, what we call desquamation, it's where the skin kind of starts sloughing. They can get high risk of infection. So these people, you might want to watch them closely or even admit them if they get really, really sick. And so that's what these people look at. Like her hand looks like it's been totally degloved, but that's what we call desquamation. So if you've ever seen someone, or if you yourself have ever had an abscess, and your skin kind of just swells up, and then as it heals and gets better, you have this flaky skin around it, and that's what we call desquamation. That's how I usually would say if someone have, how to describe it on a clinic note. If someone would come in to see me, I would say area of desquamation or area of desquamated tissue, blah, blah, blah. So that's what I saw. That's the one guy, and I swear, I think I maybe went to high school with someone who had some type of psoriasis like this, because his hand was always so scaly and rough, like when you just shook it. And I felt like I was like, it just felt really weird. And so I looked at the hand, I thought, what if he had psoriasis? And then, I think this is the last one, is pustular psoriasis. So the skin gets red, swollen, and you get these small little dots with pustules and pus-filled bumps. And it usually only appears on the palms and soles. There are several forms, including generalized pustular psoriasis, annular psoriasis, impetigo, herpetiformis. And have you guys learned impetigo yet? Like any other, I don't think you would ever would, because you don't have peds yet. Impetigo usually is common in peds patients. It's around the mouth. It's usually due to staph. But I think impetigo herpetiformis is a little bit different. Anyway, the generalized type can result in life-threatening bacterial superinfections, sepsis, and dehydration if left untreated. Because these have, but see, they have like all those pustular things on their hands and their feet. So you can see how this could get really infected quickly. These are psoriatic nails, so you can get pitting, oil spots, and thickening. And most of the patients who have psoriasis, nails are involved in 50% of patients, and with a lifetime incidence of 80 to 90%. Like this one almost looks like it's a fungal infection too. Like it's not just psoriasis, but, because look how thickened that nail is. This looks like an onychomycosis, but there's a little dotting. Hands and feet. I don't like feet. Andy loves feet. If you ever have an ingrown toenail you want to be removed, It grosses me out. I don't ever want to do it. I don't even like to, because I did one when I was in PA school. I was actually on a family practice rotation, and this kid comes in with this big fat toe, you know, it's all swollen, and basically their ingrown has gotten infected. And when they're big like that, it's hard to numb those toes up. You do a little block, so you basically, on the toe, you would inject here, here, and here. But when this is all fat and swollen, you can never get it done, numbed enough. But then you gotta take these giant pliers, and you hope and pray that they're numb. You can cut it and split it, and then you should yank that out, and you yank that out. She probably yanks it all at one time. But, and then psoriatic arthritis, like we talked about. Basically, this is a seronegative inflammatory spondyloarthropathy, because you wonder if you're worried about being RA, and you would check labs, and it actually would be negative. So these people can have it in one finger, sometimes it's asymmetric. Again, psoriatic arthritis is autoimmune mediated, usually genetics, environment, and involvement, usually 5 to 12 years after developing psoriasis. So if someone has had psoriasis and they show up to your office and all of a sudden they got this swollen digit, and I think I call it later, but we call it a sausage digit because it looks really swollen, real fat, looks like a little sausage. And they're tender, their joints are really tender, they have stiffness, pitted nails. You can also have low back pain, heel pain. So see the little sausage digits. This is its own sausage digit. But you can see they also have it in their nails as well. And this is the little fat toes. So see those, that's what you need to think of, especially with the history of psoriasis. And so how do you diagnose psoriasis? Basically, it's by history and physical, and a pertinent family history. So getting that family history of psoriasis, or like if you suspect someone who has psoriasis, you always want to ask, does any of your family members have psoriasis? And you can also take a skin biopsy. Usually the rheumatoid factor will be negative, like we talked about, seronegative. SED rates will be normal, so it looks like an inflammatory process, but it's, you know, not really, not for like joint wise. CRP will be normal, and you can have what's called a uric acid level may be elevated in pustular psoriasis. Does anybody know what else uric acid level's high in? Yeah. And so this is treatment. I know the little page is kind of long, but basically this is for patients who have mild to moderate disease. Emollient, so you want to keep their skin moist, to maintain skin hydration, and to decrease the itching, because the itching is what causes the plaques to thicken. And then these are a list of topical corticosteroids, basically just as an anti-inflammatory. With any type of steroids, which I'm sure Dr. Latassi talked about, if you overuse it or if it's high potency, you can get hypopigmentation. I don't know if any of you all have had eczema before, but if you put steroid cream on your eczema and you keep putting it on daily, after a while, after that little patch of eczema is cleared, you'll have a white patch. And it's usually, and you can see how you've been rubbing it on there because it's usually in the shape of how you rubbed it. So you gotta be careful for that. And then on the face, you wanna use there's only certain steroids that I would use on the face, and I can't think of the name, it starts with an E, that I've used before. Or you use a really low potency one if you wanna put it on their face. And also careful with kids, make sure you use a really low potency one. And there's, you know, all different types of creams, I'm sure or steroid cream topical, they come in cream and ointment, gel. So I don't remember, I thought, did she tell you guys which one has better absorption, like cream versus gel versus oil? Or did she say? I don't know if she said or not, but, I can't remember. I want to say, yeah, it's either the ointment or the cream. I can't remember which one has a little bit better penetration. You can also do clobetasol, and you don't want to occlude these with steroids. You know, sometimes you don't really, if you have put steroid on something, you don't want to wrap it. You don't want to suffocate it in there. And then you can use vitamin D analogs, topical retinoids. which she'll probably talk to you about, like Tazarac is a common topical retinoid that you can use. And calcineurin inhibitor is basically kind of a vitamin A derivative, and then other topical therapies combination, blah, blah, blah. So a combination of the super potent steroids and vitamin D analogs has better efficacy than either as monotherapy or coming in combination compounds. So these, like I said, I didn't really do a lot of psoriasis treatment. I usually, if they diagnosed them, if they had, you know, systemic disease, I would send them usually to a dermatologist to help them management. Because sometimes if it got real bad, if they had a few plaques here and there, they really knew already how to treat them. But these are probably more a dermatologist treatment-wise. For severe disease, you can do light therapy, what we talked about. The PUVA, it's real tolerated, but with PUVA therapy, you also have an increased risk of a non-melanoma skin cancers. So your squamous cells is the most common ones that you get with therapy. You can also do other systemic therapies. Again, these are things that a dermatologist would do, not you guys. Methotrexate is a cancer drug that you can use. With these people, if you do start them on methotrexate, you always want to do testing for TB and get a baseline chest x-ray. So you shouldn't be putting them on that if they have TB or latent TB. Cyclosporine, again, an immune modulator, and acitretin. I think that's the one that's like a vitamin A. And I just put this on here. I won't test you guys on this part. It's just more for your knowledge if you ever go into derm or if you're interested in them. These are just the options for, or if someone you know has psoriasis. You can also use biologics like Enbrel or Stelara. Again, same thing, screen for latent TB at baseline and yearly. So psoriasis, chronic lifelong inflammatory skin condition. You have bouts of good and bad. So you want to really talk to your patient about them. You can't tell them that, oh, you'll get over it, because they're going to have it the rest of their life. So you need to really talk with them and give them the expectations and what they may encounter. So again, if one doesn't work, you can try and use a combination with another agent, or well, if else fails, send them to dermatology and let them manage it. Y'all know what that movie's from? The guy's from?
Silence of the Lambs.
Remember he skins? Put the lotion on the skin. Yeah, it's Buffalo Bill. Okay, questions?
Well, I was just kind of curious. I mean, a lot of the professors here are going above and beyond for us. I mean, Professor Reggio like tore her ACL so we could practice on her. Professor, I think, Bean said that you need a nail.
Yeah, she tried to threaten me with a nail removal.
And
I said,
show us how it's done.
Oh, no, I will let any of y'all, if you want your nail pulled out, yeah. I was like, how awesome is that Tammy tore her ACL so you guys could do. Did you guys all practice on her? Could you tell? And sometimes it's so subtle. I mean, I don't know how much of a subluxation she had, but
They had her hanging off the table too.
they didn't have her laying on the table?
They had her, I don't like it that way, I'd rather her lay down,
So I know, I need to go back and watch the video of McNeil, because like I asked earlier on, when I was watching it, I saw him do the radial nerve, and I couldn't see if he did the ulnar. In one, somebody said he did it in one and not in the other video. Do you remember?
I only remember reading.
For the screening?
Wait, what?
Pulse? Yeah, pulse.
I thought he did.
I think he did both. At least he said he was.
Did he?
Yeah, because the one of them I couldn't see, I just saw his back in the
It was
video.
just so quick.
Yeah, and so it's like, I can't tell if he like slowed her down.
Didn't do it, so we can do
And then when he showed you guys the anterior drawer, did you use both hands? Okay.
Well, but then we had some.
But I'm not letting her take my toenail off.
Some people taught us to do.
Yeah, that's true.
If they're sitting
That's
up.
Lockman.
But if they're laying down, you're supposed to.
You use-
But he also goes on,
Sitting
because we're
up.
not allowed to sit on my foot.
So you have to hold the ankle down with one
He had
hand.
us sit on people's feet when
Oh,
we
he
were
told
doing
us
it.
absolutely not, he would die if he saw it.
But he
it.
also
Yeah,
said you
but
don't have
all
to.
orthopedic guys did.
Yeah.
That's
All
true.
of us
He said you
He
could do
taught us
it.
that way when we were in school.
Like realistically.
So when you're
You said to
lying
hold down the
flat,
ankle with one
it's
hand,
both
you can't
hands,
do it.
right?
Yeah.
But now if they're sitting, if they're sitting upright and their legs hanging,
That's what
I
Like
like
have
stabilize
one
it.
on one on the bottom.
you do this way.
In both ways, he said to stabilize the ankle with one hand and the other while they're laying down. He said, don't sit on the foot.
Yeah.
Stabilize it with your
But you
hand.
can't do this though if,
Yeah, I know, but he
We
said, don't
struggle.
sit on it, just stabilize one part with one hand and then jerk with the other, so.
I could have your part on the tibial plateau, right, or the tibial.
Yeah.
Yeah, and then